Greetings, fellow therapists. My name is Dan, and in a few moments, a current patient of mine, Michael, will be joining us. Today, I would like to specifically speak to the healer in you, that portion of you that desires above all else as a therapist to transcend the hope of your patients of restoring their health and instead to deliver assurance. In the face of a multitude of forces that tend to pull us from attending to our patients' greatest needs, what then does professing such an assurance require? My belief is it requires a close examination of what we are professing to be therapeutic. To assist in this examination, I offer a guideline definition which I call a therapeutic threshold, which simply states when in which any intended therapeutic intervention that we elect to provide actually results in imparting a therapeutic influence towards a true healing of motion versus perpetuating compensatory movement patterns. What needs to be remembered, and I believe all too often forgotten, particularly with our postoperative patients, which are inundated with varying levels of pain, swelling, motor inhibition, and restrictions of mobility, are also referencing a well-established pre-surgical movement pattern, which, to be more to the point, is deep-seated in neuromuscular substitutions, and thus inclined to retain pathomechanical movement patterns. So whether in the case of Michael, whom has elected to be a non-operative approach for his labral lesion, or for any of our patients with rotator cuff repairs whose soft tissues similarly have degraded over time, we are faced with not only a multitude of impairments to address, but one overlying existence that per person we are faced with nurturing a return of movement health and its associated dynamic stability, which is what we do. We contribute to the healing, and in these cases, the healing of motion. So if I could respectfully request of a relatively short amount of your time, I believe what I have to offer you will forever change the way you view your therapeutic delivery. And in the beginning, Michael having a history of pain, 7 months of compensating, and so his nervous system has established an adaptive pattern. So he's coming in not knowing what we're going to do. He's protective, he hurts, and his motions are with compensation. So what I have learned to be most effective is if we can calm the autonomic nervous system, calm the periphery, calm the joint itself, so that we have a template to begin with, a clean slate for the most part, so that we can actually reestablish communications, appropriate coordinations within the delicate rotator cuff and the scapulothoracid complex. And so the initial task is to reestablish a differentiation of the humeral head within the socket. So I like to establish what I call free spin, and it's simply just a sagittal plane motion. And what this offers, if we can establish that with this approach, is the nervous system starts to recognize movement as non-threatening. And so then it starts to lay down its protection, and we can then grade a progression of motor activation. So 2 analogies that I like to share with you. One is as we button our shirts. If we start in the right hole, we'll end in the right hole. So with movement, if we start with the compensation, once the motion is in flight, it's very difficult to change the outcome. And so I like to begin with a correct execution, a success, and then we can build on that, and letting that therapeutic threshold be the determinant, the barometer that I monitor, that we stay within that we can grade a progression of natural strengthening and conditioning of the appropriate muscles. The other analogy that I like to use is like a dimmer switch on a wall versus a click-on natural abrupt light switch. With the law of the motor unit, that's the way muscles are supposed to activate, from small groups of fibers to larger groups. And so with substitutions, it's usually abrupt with the larger muscles, and the smaller, weaker muscles get left behind. So a very gradual, subtleties matter approach. Okay, so that's what we're going to execute here with Michael. So what I'll ask him to do, and again, this can be with post-operative patients as an alternative to pendulums, which as we all know, are very difficult to perform. Michael didn't require that, but it's a mirror image of what's possible with this application. So Michael asks you to put your right hand on top. And so what we're wanting to do is the left arm, the involved arm, to go along for the ride. So the right arm will do all the work. And in the beginning, a person in pain, that little motion can be enough that it can either set the stage for a change or perpetuate what the person came with. This is a really helpful application prior to your manual efforts of passive range of motion on the table. So if you begin your patient with this, you get them on the table and their apprehension is diminished. You can go right to their in range and be effective with gaining motion. And then after you've done your manual work, you can have the patient come back to this, and the motion that you've gained, as I'll show you, can be utilized. So that's the first application. We want to accomplish the free spin, let the person gain trust of the tool, and then we progress accordingly. So then Mike will ask you to put your hand on the back side here, and then we can move down the kinetic chain and involve more of the distal motion so that the person just looks like a more natural movement. And then as he moves into the active assistive stage, and then we're going to progress without the support of the non-involved arm. Okay, Michael, you can take your right arm off. And so what I'll do now is ask him to progress upstairs. So Michael, go ahead and step forward here. And as you can see, we're simply just grading the elevation. So with the intent of reaching to full elevation eventually, we're just gradually accomplishing that. So now I'll ask Michael to just produce that motion on his own. And you can see that the tool supports the weight of the arm, so as he moves distally away from his body, then the tool continues to stay with him. And I'll show that again when we show the wall mount, how it compares to pulleys. We'll go up one more stair height. Okay. Now he can also, Michael, I'll have you put your left foot in front of your right, just like that. When we reach higher, we tend to use more of our body. And so this allows him to work his lower extremity in the act of supporting reaching. And as you can see, if there's a gradual restraint here, as I'm watching the details, we can look for substitutions. I can also work with my hands to guide the complexity of articulation, so a mobilization with movement where I don't have to hold the weight of the arm. We all look for that third hand, and this offers the freedom to both of us so that it can be a pure motion with the appropriate assist. So I can perform a depression of the humeral head, and I can perform an upward rotation of the scapula, or whatever is necessary. And then if you recognize signs of fatiguing, then we simply work our way back down. So just do a couple strokes, Michael, all the way down. And then what I'll do is I'm going to walk you now through, as I worked with Michael, we recognized impairments on a motor level. So he was performing, the typical hiking of his shoulder, and we recognized his force couple wasn't keeping up with the elevation, and his scapula also wasn't supportive of rotation, so that scapulohumeral rhythm was in a disconnect. So Michael came with a multitude of joint restrictions, some imbalances of weakness and overpowered muscles, and so the typical manual skills can then blend with the support of the clinical tool, the upper extremity ranger. And so I'll walk you through that sequence now. And what I've highlighted essentially is the muscles of the rotator cuff and the serratus anterior and the lower trapezius. So muscles that we typically work with on an impaired level, we can activate, and then the good news is we can, with that activation, put it right into motion. And that's what helps the nervous system make sense of it and integrate it into the process of motor control. And so the first one that I want to begin with is the supraspinatus. Now this can be anywhere from the natural carrying angle of the elbow, and you can perform the empty can motion in the scaption plane. But with Michael, what I found was that if we start at a little bit taller height for him, because he's further along, so what I'll do is have him just do a partial pronation in the scaption plane, and I'm looking for activation of that muscle. And then as I feel it, and as Michael feels it more importantly, then we'll preserve that, and then we know we're not being overpowered by the deltoid, so that initiation of the force couple can begin. So Michael, do that, and then go into, let's do it this way, and then blend right into the finishing with a natural reach. So it's a subtle transition, activate, and then utilize. And now I'm going to bring him up, having that on board, bring him back up to the elbow at 90 degrees, and whenever possible, like for that one, I just ask him to feel like they're dumping out a glass of water. This one I ask him to think about shaking someone's hand, and so this is for the serratus anterior. So it's a subtle motion you want to describe to the patient to initiate these intentions, but not racing through and performing the full motion, because the motor activation is within the engagement of the motion. So a lot of attention being paid to the communication with the nervous system and the actual outcome mechanically. And then finally we can just go into rotation, so internal rotation and then into external, all with the support of the tool. And we're not applying resistance, we're just awakening muscles, because that's the first level of strengthening. If we race to TheraBand or resistance of any type without these muscles being assured of being active and being able to keep up with the motion, then we're just reestablishing or reinforcing something to have to take over and continue the compensation. So that's my belief, that we have to have that activation if we're ever going to get to appropriate resistance. Okay, so we'll stop there and we'll transition to the wall mount now for the higher levels of elevation. So what I'm asking Michael to do now is to demonstrate his capacity of elevating his arm. And what I'm looking for is essentially a point that he begins to demonstrate a necessity of support. And so what I'm preparing for is the application of the wall mount. So what I'll ask Michael to do is, Michael, just go ahead and elevate your arm. And what I look for closely is just the point where the congruency of motion begins to demonstrate the activation of challenge. And so it's just a recognized point of struggle, and that's obviously something that is the precursor to scapular or shoulder hiking, and ultimately impingement. And so at this stage, Michael's doing quite well, mostly free of pain, but we recognize in the act of somewhat of a disconnect that he's still susceptible to some micro trauma, and we want to avoid that as he progresses into full activity. So we've progressed with Michael's actual elevation now, and Michael still has a bit of impedance of elevating his arm through 90 degrees. He labors with a bit of disconnect still in the scapulothoracic region and still with the force couple. So what I've done is I've adjusted the height, and we have the base of the UE Ranger in here, which is a matter of just inserting it into the frame. And then what we want to do is have the patient maintain contact. So it's somewhat of a closed chain support. And what we're trying to do is we're trying to work from his level of success. So in the neighborhood of approximately 80 degrees where he's still doing well, and then slightly through 90 degrees. And we're looking at that as a training interval. We try just to progress through his successes, condition those with appropriate strengthening and conditioning, and then we build forward, just in normal therapy. It's simply utilizing the tool to work with the nervous system and the appropriate graded progressions. And so Michael will show now that he's elevating, and here's where we want to take into application the full upper extremity. So we want that humerus to guide into external rotation to clear that acromion. And in that context, we're working the external rotators and the whole kinetic chain. Michael, I ask you to put your left foot just a little bit forward. Now, what I found to be helpful with bringing on the lower trapezius as a person's elevating is to actually just think like he's hugging someone. So we'll use just his left arm, but just the act of out and around, like a circumduction, activates really nicely the lower trapezius. And so he's finding that muscle, and as I demonstrated earlier, I could be providing manual support and just can really become specific with his actual needs and providing that support such that, again, the nervous system can work with it. He can transfer his weight forward by using the lower body. So as you come up, Michael, just transfer your weight onto the left leg slightly. And then we can work that on a full body scope. And then as he becomes fatigued like we expect, then we would work him down. But I want to work him at that level with the preparation we did on the floor and the stairs, and we work towards this, and so that's a circuit of training. We'll also do some work in sideline, which I'll show, and then in hook line. So if we went back to him playing the trombone, you recognize that his left arm was pretty static, but yet that was a high demand for him to support the weight of that trombone. How much does a trombone weigh? Somewhere in the neighborhood of
15 pounds.
15 pounds.
10 to 15 pounds.
10 to 15. So that's a high demand, and as he performs that motion, as we know, that's a longer lever arm, so he's having to manage that. So that's just a high level of conditioning and proprioception, dynamic stability. It's all in there, and then his other life requirements. So if we wanted to work on stability itself, we could position him, and then we can do some rhythmic stabilization with my hands, or he could turn his own body. All those applications are possible as well. So we'll bring him down now. It's just a simple twist of the knob there, and just lower it, and then Michael, just kind of do a little conditioning now, just some lower level, kind of a cool down. Okay, now I'm going to bring him out, and I always like to end just on the floor and just let him have the comfort of finishing with 3 to 5 strokes. Now what I'd like to emphasize with the application of the wall mount, differently than pulleys, and the Ranger itself in all applications compared to pulleys. When we grip, and this is what I learned as a shoulder patient, when we grip, there's 3 things that occur. One is that it's a component of the fight or flight, the startle response. So we don't need to remind that nervous system of the need to protect. When we act in the initiation of a grip, that's occurring. It's also, when we distally grip, it's a requirement of the proximal muscles to stabilize. It seems like a small act, but that simple motion with pulleys is enough that we could prematurely fatigue the weakened muscles. And lastly, it's a co-contraction. So when we grip, we're working against ourselves as we try to elevate. So the open hand is a critical piece. Now you can try that on your own arm. I'll ask you just to elevate your arm and just feel the level of effort. Say you grade it as 1 pound of effort to elevate your arm. And then as you elevate, after doing that a few times to get a feel for the amount of effort, then as you go up, gradually close your hand into a 1 pound grip. And notice that it requires an amplification of your effort, such that it's pretty significant. So if you think of a painful patient, why would we have them be gripping? So it's just the subtleties that matter when we're trying to work with the nervous system and resolve the history of compensations. Okay, so what we've done is we've taken the base off the bottom of the Ranger, and the tool now can be used in more of an open chain application. And we're still looking at that interval where Michael has a continued requirement of strengthening and motor control. So we'll still work in approximately the 80 degrees to, let's say, 110. So gravity reduced, so we have the benefit of that, so we can work more of a conditioning. And he has the support of the table for his posture, so we can just get a little bit more isolated to the shoulder with this application. The other opportunity is for me to do manual work differently on his, a portion of his history was his AC joint, having some arthritis, so I can be isolating that. I can be doing some cervical work. I can do torso work, which we're going to transition from here to side lying, and then I can be more specific with his ribs and his scapula. And so it's just another form of conditioning. Again, he could position this wherever there seems to be an interval of challenge that needs some more emphasis of stability, and then I can work proximally to distally with him, offering some rhythmic stabilization in different planes. You could also work on some pectoral stretching. So the application is endless in just sorting out your patient's specific needs and you know, identifying the application accordingly. And then Michael just finished by just going up and down a few times. And then go ahead and on your next one, just go ahead and bring her all the way down. We'll stop there. And now we'll move into the side lying application. Okay, so we've moved Michael now to a side lying position. And this, again, if you think of the powder boards that we used to use as therapists, we're trying to just move with gravity reduced. Table slides is another more current application, but that has a lot of friction. So this offers a seamless path of motion, gravity reduced, and again, it's somewhat of a dynamic control. But what it offers me as a therapist is I can be very specific with his ribs and his scapula. And oftentimes, you know, mid to lower thoracic is involved with the shoulder. So this offers an opportunity to integrate that portion into the dynamics of full body motion, and allows me to be more specific to the patient's current needs. So again, versatility and specificity. Okay, now we'll finish with going finally to standing with an application for the patient to work on this at home. If you recognize the need, or sometimes patients are compromised with their ability to come to therapy these days with the challenges of insurance, high deductibles. And so what we're doing in our clinic is we're loaning these devices, these tools to our patients with respect to those concerns, and ultimately achieving a higher level of outcomes, because patients are able to do for themselves at home what is necessary, what is specific to their current needs, and therefore they come back to the clinic with a high level of a carryover and a total reduction of expense to the insurance companies, so it's serving everyone. And that's the ultimate for our intent of a high level of outcome. So finally, we're applying the closed chain application that we showed with the wall mount, but this being a door mount, which a patient can take home with them, and then they can perform that higher level of elevation against gravity. So Michael, go ahead and just elevate again within your tolerance. So I'm working again that interval where he still is having a challenge, and as you feel comfortable with that, then just try to transfer your weight into that motion, just slightly, just so you feel like your whole body's supporting it. And then I could, again, combine the neuromuscular re-education, so asking him to think like a hug motion to get that scapula engaged. And also here, it's a little bit more specific to his rotators. If in that sequence of scapulohumeral rhythm, I can target the external rotators here, and then I can integrate that into motion. So target, and then integrate. And that's, again, what we can't do with taking TheraBand or dumbbells and expecting the nervous system to know what to do with it when we go into using our arm. So it's the coordination of the nervous system that makes this tool set apart from our previous traditional efforts. And similar to the parameters we're versed in with our profession, just the normal conditioning components. So looking for those details, and that's what we describe as true healing. So thank you very much.